Welcome. My name is Ty Vanabo, and I'm going to talk a little bit about Lewy body dementia. Lewy body dementia is the second most common form of dementia behind Alzheimer's disease. Though there had been some previous speculation about the disease, it was first described specifically in the 1960s. Lewy body dementia has some genetic component that has been noted, but is generally considered to be of random pathology. Though the disease has been identified for some time, it is still likely underdiagnosed due to a lack of specific and sensitive criteria to distinguish it from other types of dementia. Lewy body dementia is most common in the male population and in individuals over age 75. On assessment of an individual with possible Lewy body dementia, the clinician Farlow notes that the presence of dementia is an essential to the diagnosis. Farlow then defines dementia as a progressive cognitive decline of sufficient magnitude to interfere with normal social and occupational functions, or with usual daily activities. Generally, these types of information are gathered from a history from the patient or family that may include difficulty maintaining attention, difficulty driving or performing on the job. Farlow then describes three core clinical features that assist in the diagnosis of Lewy body dementia. First is cognitive fluctuations, which are described as episodes of some loss of motor or speech abilities that are generally short in duration but can be confused with syncope, seizure, or even stroke. Patients may also be drowsy during the day, take naps longer than 2 hours, have episodes of what people may describe as staring or disorganized speech. Visual hallucinations are another core feature that especially helps in the distinguishing of Lewy body dementia from Alzheimer's disease, with hallucinations including episodes of seeing flashes or images in the peripheral of the vision, or even hallucinations where the patient is interacting with people that are not visible to others. A final core feature is Parkinsonism, where the patient may experience limb rigidity or gait disorders similar to Parkinson's disease, but generally at a reduced level and with symptoms occurring nearly equally bilaterally. Other associated features that may help in establishing a diagnosis of Lewy body dementia are sensitivity to antipsychotic medications, repeated falls, syncope, autonomic dysfunction, which includes urinary incontinence or retention, constipation, and other GI issues, olfactory losses, and also anxiety and depression. The visual borrowed from the Lewy Body Dementia Association website is shown here and depicts some of the features noted in diagnosing Lewy body dementia. The slide here shows Lewy bodies noted within a brain cell that provides the only definitive diagnosis of Lewy body dementia. The diagnosis of Lewy body dementia is made nearly completely based on clinical criteria, with further evidence being used only as supportive to the diagnosis. As with most brain-related diagnoses, other acute pathology must be ruled out first before diagnosing Lewy body dementia, such as seizures and delirium. EEG studies can be helpful in ruling out seizures, and MRI and PET scans can be supportive with noted atrophy and decreased perfusion to specific areas of the brain. Tools used in determining cognitive status include the mini mental state examination. In planning care for patients with Lewy body dementia, there are only a couple of medications that have shown any real ability to improve symptoms. Both, however, have proved to be very minimally effective. Cholinesterase inhibitors are used with some improvement in cognitive function of patients with Lewy body dementia, but it was noted that though the results are statistically relevant, they are not usually clinically significant and generally tend to fade over time. Many side effects are also present with these medications, including nausea, diarrhea, syncope, and severely increased Parkinson's symptoms that make the medication use very controversial. Medication therapy has shown some similar improvements in cognitive functioning among patients with Lewy body dementia, without the great list of side effects seen with cholinesterase inhibitors. However, the results of these therapies are also minimal, and like cholinesterase inhibitors, generally fade away with extended use. As medications are generally minimally effective, behavior therapy is often more important in easing the symptoms of Lewy body dementia. Some suggestions from the research include altering the home and sleep environments to make them safer so that individuals struggling with the disease do not get injured due to sleep disturbances or Parkinson's symptoms. Physical therapy and mobility aids can also assist in minimizing some of the Parkinson's symptoms. Cognitive symptoms can be eased by both building consistency in schedule and in the home, and minimizing stressors such as changes in schedule or activities that place increased. As with all dementias, the prognosis for Lewy body dementia is very poor. Cognitive and Parkinsonism symptoms will continue to get worse until they eventually lead to death. The average life expectancy for patients with Lewy body dementia is about 7.7 years from diagnosis to death. This is a slightly short survival time than with Alzheimer's, and Lewy body dementia is also noted to display a greater loss of functioning when tested using annual mini-mental state examinations as a measure for cognitive status. Due to the high rates of visual hallucinations and increased Parkinsonism, there is also a very high rate of institutionalization for patients diagnosed with Lewy body dementia. These are my references, and I thank you for listening to the presentation.